Okay. Relocate, I know there's also been lots of questions about why can't we stay here? Why can't we not stay on this site? One of the things is, again, and I guess I have felt very strongly about this, is that if I'm going to be involved in designing something, we need to be able to design it for the way that we want to provide care and the way that we would like the hospital to be designed, rather than trying to design something that's going to fit on the site, because then I don't know that I would have anything that's much different than what I have right now, except of course that it would be newer and that would be fun too. But it's all about those adjacencies and trying to be able to design and lay out that hospital how you want that. And what we learned and what we've been learning is that it is the wave of the future to design hospitals on a greenfield site. We've visited hospitals. I think I've visited probably 4 or 5 of them. They've all been on the greenfield sites. They've all been some as far as 5 miles away out from their town. And it is about having the space to expand for growth and for able to design your facility the way that you would want it. For growth and expansion, now again, Jamestown, we still think that there's some growth that can be had in Jamestown. Can we do everything that they can do in Fargo and stuff? No, we would love to bring those kind of services here. We have to look at what we can do and do well here to try to keep citizens in the community, to stay in the community to get their health care. But without specialists, there are just always going to be some things that you need to go elsewhere to get. Again, the rooms, and we looked at the rooms being private. One of the other things that we've really learned is that the rooms really need to, besides the lighting and the environment that helps with the healing, there needs to be enough space for the families. Care has really changed. Families expect to be able to stay in the room, have room in that room to be in there with their family members. And so the way they design those rooms now is that there's actually an area for the family, there's an area for the patient, and there's an area for the nurse and the physician that are working in there without everybody crossing each other's path all the time. And then also we looked at having this as being a medical campus environment. We don't know exactly what's going to happen to this site. All we know is that we've been told that you need to have at least 40 to 50 acres so that you have room for expansion or for whatever other kind of growth might come with it. And also the fact that we would like the physicians and the clinics to co-locate on this location with us. A helipad is also something that's very important to us. Here now in the emergency room, if we have a patient or a baby that needs to be sent to Fargo, a lot of times the babies, because they will send special teams to come pick those babies up and take them. They fly, and it's either by helicopter, fixed wing plane, but even a helicopter, if we're going to transport a patient, the helicopter has to land at the airport, the ground ambulance has to go get that crew, bring them to the hospital, then get the patient ready to go, transported by ground ambulance again, out to the helicopter, out to the airport again, and then leave. And that adds at least 15 to 20 minutes of time onto that transfer, where it's just quicker for us to put them in that ground ambulance and just send them. But there's some specialists and some physicians that are accepting them that want them to come in that helicopter. And so we will be able to have a helipad out there, and we believe that to be a great advantage, as does the physicians. And I just wanted to show you, this was just not exactly what a patient room is going to look like in our new facility, but if you've been in any of our rooms, you would see that this is quite different from our rooms that we have now. Our bathrooms are very small. They actually just have a toilet in them. All bathrooms now are designed with a shower, a sink, and the toilet in the bathroom. Most of our rooms don't even have showers or tubs in them. We still have the community showers and stuff that you have to travel down the hall to use the shower. So those are things that we just feel very strongly about, that the patient needs to have, and believe me, the patient also feels strongly that it's something that they should have. And just the extra room and stuff that is around that bed for families to sit and for staff to be able to move around. So, okay, Ellen's going to talk a little bit about the demographics.
I wanted to echo Marty and Cindy's welcome, and thanks for braving the elements of coming in tonight. A little bit about the demographics. Got these statistics courtesy of the JSDC. Current population, this is going back to 2005, was 61,454. And as you've probably heard a fair bit in the past, there's a phenomenon going on called the population redistribution that is heavily impacting the over 65. That's where we're seeing some significant increases over the next 10 to 15 years. And actually, if you look at the statistics, and again, these are from 2005, at that time, 17% of the population in this area was over the age of 65, 10,500. And if you look going down 2010 and all the way down to 2020, it's actually doubling. So the senior population is going to be a much larger portion of the group that we treat. And this is both a challenge and an opportunity for us. It's a challenge in that we have to make sure that our facility is very ambulatory, easily accessed in and out, that we have the technology to support this population group. And also, it's an opportunity in the sense that it will mean more Medicare patients for us. And Medicare offers some special programs with help with the financing for construction of a hospital that we're talking about. So again, it's both an opportunity and a challenge for us. And the projections, the over 65 group is as you all probably know, the fastest aging group in the country, and that's not going to diminish or turn around anytime soon. A little bit about critical access designation. I'm sure most of you have heard about this. We are in the process of converting and are probably within a few days of actually finishing the conversion. But critical access is, by and large, a CMS, Center for Medicare and Medicaid, reimbursement designation. That's really what it is, and that's what it means to us. And one of the things it does is provide a reimbursement mechanism which will actually elevate our level of reimbursement for Medicare to cost. And cost is as good as it gets with Medicare. And the fact is we will get cost plus 1%. And North Dakota actually also pays, the North Dakota Medicaid program pays on a cost percentage. So the total of these two is over 40% of our payer mix, 40% of our volumes. And as I mentioned earlier, one of the significant factors of the critical access designation and the Medicare program is the way they reimburse for major capital projects, and we're positioning ourselves to take full advantage of this process. But one thing it does mean is there's no changes in the level of care. Nothing is going to change in terms of the level of care we provide. We'll continue to have the full scope that Cindy's mentioned and actually look for opportunities, whether it be orthopedics, oncology, ENT, programs like that. We're going to take a close look at those to see if that's the right thing for Jamestown. It does contain a few restrictions. They try to keep the playing field level with the smaller critical access hospitals and the larger PPS ones. One of them is there's a 25 acute care bed limit right now. As Cindy mentioned, I think we're 36 beds, or we have 36 beds. We don't physically have 36 beds. Our average daily census is now 13. So this is a right sizing for us. This is an opportunity to right size. And in addition to this, there will be a few extra beds called observation beds, and those are normally used for post-surgical patients, those that stay up to 24 hours that maybe had a surgical procedure. So we will actually be able to house between 28, 29 patients right in that range. One of the key components of critical access is you have to be 35 miles from the next closest critical access hospital. The current site, and just to clarify this, the current site does qualify. We are 35.8 miles from the Valley City Hospital, Mercy Hospital, Valley City. And going west to the location of the property we're going to be building on is actually about 1.5 miles further away from Valley City, so we're safer, I guess you would call it. Going east was not a possibility due to this restriction, and this is a no compromise, no negotiation with the federal government. This is how the program was set up.